I'm Dr. Vijay Neglur, diabetologist from Mumbai, India. And it's nice to be with you, sir. And I'm speaking to Dr. Michael Nock, Professor of Diabetes from Germany. Good morning, sir.
Hello.
I heard your lecture. It was very, very interesting. You said about new therapies in diabetes. What's the need to have new therapies? We have so many drugs. Is there a need to have new therapies in diabetes?
I believe yes, because we still cannot address all the risks that are associated with diabetes, and we still have no medication that interferes with the progression of type 2 diabetes. And we at least see the chance that pharmacological treatment can come close to what bariatric surgery can offer to patients now. And as you know, this may be associated with some side effects, and it's an invasive procedure. So if you can do the same thing with pharmacological treatment, I would prefer that.
That's very good. There have been a lot of gaps we have still in managing type 2 and type 1 diabetes, as you said very clearly in your talk. You said about type 1 diabetes and immunotherapy. What percentage of the beta cells in type 1 diabetes are still dormant, which can be reactivated for the patient to secrete insulin? The teaching is that the most of the beta cells are gone in type 1 diabetes because of immune destruction. And you offered immunotherapy to these patients to prevent the further destruction of those beta cells. What percentage of the beta cells, on an average, in a patient with type 1 diabetes would be existing so that this kind of immunotherapy is effective in what percentage of patients?
So I think we now believe that the beta cell mass has to be reduced to like 10 to 20% before clinical overt diabetes results. But this number is in a way misleading because it's a steady state of cells growing and coming into existence and being destroyed by the autoimmune mechanism. So a good colleague of mine has published a patient who had had type 1 diabetes for decades, and they could still find evidence of beta cell neogenesis in this pancreas. So I think this will never stop, and since the beta cells regrow, you will always have a chance to protect cells from immune destruction. And with type 1 diabetes, we are far from replenishing beta cell mass to what it originally was. But we know very well that even like 20% of the normal beta cell mass helps very much to control diabetes.
And to reduce the dose of insulin.
Even if the patients need insulin under those conditions. But regarding complications, they are much better off.
You also mentioned about glucokinase stimulation. There's an enzyme which actually traps glucose into the cell. This is controlled by insulin. You said the activators of glucokinase receptors are in a big way to treat diabetes. Is there a role of it to play in the Modi type 2 variety?
Oh, that's a different story because we know that glucokinase mutations are cause of Modi, I think type 3,
type 2,
type 2, you know
yes.
better. But whether you can rescue that with activators, I have not seen any data. So some of those mutations may help. It may help. In others, I doubt that this will be the case. But the problem is really that first of all, you have glucokinase both in the beta cell and in the liver. So whenever you have some activity in the beta cell, you will also have something in the liver, and it may not always be good to both organs. And the other thing is, since intracellularly glucose 6-phosphate is what triggers all those things, and you always have high levels of glucose 6-phosphate if you activate glucokinase, it will make the beta cell believe that there is a lot more glucose around than there is. So it almost certainly will lead to hypoglycemia, because while you have hypoglycemia, the glucokinase still transports a lot of glucose into the cell, and the beta cell is happy and thinks there is normal glycemia, and then it still secretes insulin. So I'm not very optimistic that you can make major use of glucokinase activators.
Okay. You said in the last slide that some topics you would not like to speak on in the interest of time.
That was
One was 11-beta hydroxysteroid.
Yes, yes.
Do you think it has any role to play if you have a medicine which induces the action of 11-beta hydroxysteroid enzyme? Will it also help the patient to reduce the weight and the blood sugar? Because we said this enzyme basically stimulates the adipogenesis, especially in the visceral fat. So it produces what is called as a metabolic syndrome, predominantly having large amount of fat in the viscera.
Yeah.
If you think that it could be a new hope for patients of diabetes management?
Well, the clinical results I have seen, and there are very few publications at the patient level, are not very convincing. So it doesn't change HbA1cs very significantly. But maybe, as you said, the purpose would be a different one. But until now, we in clinical practice rarely diagnose the metabolic syndrome outside type 2 diabetes,
yes.
so independent from type 2 diabetes. So, and I'm not aware of any studies addressing obese only people with some facets of the metabolic syndrome. Maybe that's a better target population.
And last question before we close this discussion, do you have any special message because this will be listened by all the doctors from India. So any special message on the topic that you discussed about the newer therapies in diabetes, where is going to be the research area will be focused on, which area? It will be on insulin resistance, insulin secretion, or both, on obesity, where you think the area of research will be focused on?
So I think a solution to the body weight problem will be a prime problem
priority
to be addressed. And fortunately, we now have some ideas, and especially these dual or tri-agonists addressing GLP-1 receptors plus other endocrine receptors involved in the regulation of body weight. I think they raise some hope that a couple of years from now we can do much better than we can now. And this is so usually we complain that type 2 diabetes is a chronic disease, it doesn't go away, and for the time being that's still true, but it's also a long-term disease, and if you cannot solve a problem today, you may be able to solve it a couple of years from now, and most patients have that time. So I would stay optimistic and just follow the science and the developments and the new therapies that will arise from it. So there is no reason to give up at this moment in time, rather to be optimistic that we will be better off in the future.
Yes, wonderful. Thank you very much. When ending on the note of optimism that there is going to be a cure or a remission in type 2 diabetes.
Absolutely.
It's in your future.
Thank you for the questions.
Thank you for answers.